Good evening, everyone.
Good evening, Dr. Chaudhary, sir.
On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this 14th episode of Endocrine Talk Show. And today we have interesting topic on insulin resistance. As today I was listening to the latest ESH guideline on the hypertension management, they are focusing on the beta blocker as well. So beta blocker may now also come as a first line therapy in management of the hypertension. Similarly, pioglitazone also emerged as a key therapy in the management of diabetes. So there are various options available to treat the insulin resistance. Which one is the right option, and how can we better target this insulin resistance in the management of type 2 diabetes? That we are going to learn today from our experts. And to moderate today's sessions, we are having with us our post-director for the program, Dr. Subhankar Chaudhary sir. He is a professor and head at Department of Endocrinology, SSKM Hospital, Kolkata. So with this word, I hand over the digital podium to Subhankar sir and request him to introduce our panelists for today's program. Over to you, sir.
Very good evening. Once again, welcome to all of you to this monthly endocrine talk show. And this evening, we shall talk on a very common subject, type 2 diabetes, and especially focusing on insulin resistance. We have, as usual, 4 eminent experts from across the country. So, Professor S.V. Madhu, thank you very much for joining. He is Director, Professor, and Head Department of Endocrinology at the University College of Medical Sciences and GTB Hospital, Delhi. He was a past president of Endocrine Society of India, past president of RSSDI, and is a current editor-in-chief of IJDDC and IJEM, 2 of the most prestigious journals, in my mind at least, in the field of diabetes and endocrinology in our part of the world. So, and of course, he has got numerous accolades, acclaims against his names. Next, we have Professor K.M. Prasanna Kumar, once again a past president of not only the Endocrine Society of India, as well as the RSSDI, has also been the president of the Indian Thyroid Society. He is a consultant endocrinologist at the Center for Diabetes and Endocrine Care and Diabetes Care in Bangalore, who was formerly head Department of Endocrinology at MS Ramaya Medical College, Bangalore. And again, he has had a wonderful tenure and continues to inspire all of us with his acumen. We have Dr. Prakash Keswani from Jaipur now, who is senior professor and unit head Department of Medicine at SMS Medical College and Hospital, Jaipur. Has worked in different positions in state chapters of API and RSSDI, and he was the organizing chairperson for the last very successful SECon in 2022 held at Jaipur. He has numerous publications to his name. And last but not the least, we have Dr. Manas Pratim Barua, who is promoted director and head of the Department of Endocrinology at Apollo Excel Care Hospitals at Guwahati. He was a former editor-in-chief journal of Medical Nutrition and Nutraceuticals, associate editor of IJEM, associate editor of Thyroid Research and Practice. He has more than 200 publications with more than 6,000 citations and so many scientific communications. Welcome, Dr. Manas Barua. So what we had suggested is this evening we shall talk about type 2 diabetes with a special focus on insulin resistance. We all know that type 2 diabetes is, of course, importantly contributed by insulin resistance, but there is an important element of beta cell dysfunction as well. And while these were the conventional pathogenetic mechanisms of type 2 diabetes, we subsequently understood that there are so many other factors, the kidney, the GI tract, the brain, and so on and so forth. Other factors are also important, but I feel still the most important ones are insulin resistance and beta cell dysfunction. And there has been numerous debates. I have also participated in some of these as to what comes first, the chicken or the egg. So similarly, what comes first in type 2 diabetes? What would our panelists feel? Whoever wants to take the question, is it insulin resistance or beta cell dysfunction? Yeah,
Start.
Manoj.
For type 2 diabetes, of course, we have to understand that it's insulin resistance which would come first, because any susceptible patient is there is a genetic susceptibility, there's for having insulin resistance, and usually insulin resistance, the phenotypes manifests by the end of the second decade. And of course, if the patient keeps on gaining weight, obesity also adds to that. But when a person becomes insulin resistant, and there is hyperinsulinemia, because the muscle cells, particularly liver cells, are not accepting the glucose which is circulating in the blood, and because of that, to compensate that, there will be hyperinsulinemia, and there will be various other phenotype factors or manifestations which are because of high insulin. For example, PCOS in the second decade, usually manifesting in the second decade in many girls, is because of increased insulin activity at the ovaries causing testosterone secretion. That's one example. So once a patient, a susceptible patient, having insulin resistance in the background, and there is a continuous insult to the beta cell because of various reasons like environmental toxins or disruptors, or even some beta cell centric genes which might be defective, causing beta cell apoptosis or progressive failure, and then the patient becomes dysglycemic. So actually, type 2 diabetes is actually one part of the whole story of insulin resistance, because insulin resistance can manifest as dyslipidemia, PCOS, and various other manifestations. Even cardiovascular disease also partly contributed by insulin resistance. So I think very simplistically, I would say, if we consider type 2 diabetes alone, insulin resistance comes first, which is followed by progressive beta cell dysfunction. In short.
Right. I also tend to agree on those lines. So there are also evidence has shown that no, beta cell dysfunction comes first. But even let's not get into this debate for too long. But we all again understand and agree that it is of heterogeneous pathogenetic mechanism. Type 2 diabetes, it's not just in one type. And both beta cell dysfunction and insulin resistance are there, as Dr. Manoj Porwa already said. So how do we sort of find out? And a corollary to that would be, can we therefore individualized treatment as to an individual with type 2 diabetes who has predominant insulin resistance versus predominant beta cell dysfunction? So should our treatment be different in these? Can we ask the vast experience of Dr. Prasanna Kumar to take on this issue? And at the same time, let me appeal to all of you across the country who have logged in to put in your questions, because you are the main people. So whatever questions are handed over to me, I'll definitely distribute amongst our panelists this evening. So Dr. Prasanna Kumar.
Thank you, Dr. Subankar. Good evening, everybody. Our focus is insulin resistance. As I was talking to Dr. Prakash, whose thesis was insulin resistance, our concept of insulin resistance from 1970, 80, 90, 2023 is changing. The definition, understanding, assessment, and clinically how to recognize and all that. So basically, what is insulin resistance, whether it is in a clinician's terms or whether it is a biochemical change? All of us know inhibition of insulin action on glucose transport from extracellular space, whether it's blood or interstitial, into the cells of insulin sensitive target tissue is the most important thing is skeletal muscle. That is what we see. So response to insulin, when the blood sugar drop is very high, more sensitive, less it is. Now, as you said, whether these things are important, yes, as you said yourself, type 2 diabetes is very, very heterogeneous. It is not a simple thing. Even type 1 is also heterogeneous. That is what we see. There are various factors which they say. People have been trying to say, what was the old definition? Let us go back 40 years back. Then there was IDDM, NIDDM, non-insulin dependent. What did you mean by non-insulin dependent? There were two categories, obese and non-obese. Why did they make? Is it based on pathophysiology or the clinical feature or insulin resistance? People didn't know that. And what is insulin resistance? Everybody has insulin resistance. Nobody should run away with the impression, oh, this is insulin resistance. It is not like a black and white. It is gray. Where does it start? Look at Dr. Yagnik's data. As early as 1 or 2 years, insulin resistance starts. Everybody has insulin resistance. It's a relative term. I have more insulin resistance than you or anything. Can we make out clinically? Yes. All obese people have more insulin resistance, irrespective of their diabetes or not. Even thin people also have insulin resistance. How do you make out clinically? Next question, why all this hair splitting is, can we clinically categorize people into different various types? Simple type 1, type 2, people requiring insulin, not requiring, responding to tablet. All of you must have seen a recent one. What is that recent study which showed a lot of weight? This is all new diabetes in Kenya, that is known as Andy study, where they studied 114,000 and all patients, if my memory is right, and trying to categorize people. Why should I categorize people? What should be the criteria? The criteria in this case, what they use, were dependent on clinical upset. What did they take? GAD antibody, age of diagnosis, BMI, HbA1c, HOMA estimate. Can you do all this clinically? No, you can't do HOMA clinically. You cannot do GAD antibody, it's a blood test. Based on this, the different types of this one was done. The idea is whether we can have a different cluster of diabetics based on all these 5 factors. This is a guideline to see how the disease progresses. Complication occurs, whether cardiovascular, renal, and others. What did they divide? They divide into 5 types. Basically, this is Scandinavian one. Remember, it's not Indian. They divided into severe autoimmune disease known as SID. They also said severe iron deficiency diabetes, insulin deficiency diabetes. Like what they were telling just now, Dr. Shubhankar told you that the baseline is insulin resistance. So severe autoimmune, severe insulin deficiency. The third category is severe insulin resistant diabetes known as SID. This is the third group. What was the fourth group? The fourth group was mild obesity-related diabetes. The fifth group is mild age-related diabetes, MUD. So whether it is SID or SID or SID or MOD or MUD. Now today's discussion is not this because every book or every article carries this. We should try to understand this 114,000 was Swedish population. Do you think it is relevant to others? After that, many papers have come. One paper has come from China. The Chinese and the American population was studied. The subsequent also came taking into European population. We also have Dr. Mohan's data about how India. These features are not uniform at all. What the Asians, South Asians, Dr. Mohan has published is that there are people where there is combined insulin resistance and deficiency. Probably Indians have least of severe autoimmune diabetes. Indians have a mixture of both insulin resistance as well as insulin deficiency. And from Yagnik to everybody has shown, though Indians have a low BMI, they have a high insulin resistance. Now coming back to Shubhankar question, what did you inherit? Did you inherit diabetes? Did you inherit insulin deficiency? Did you inherit insulin resistance? Probably everything. Suppose genetically 50% is genes. Suppose you inherit a gene which clicks the proteomics and your apoptosis of beta cells is already determined that at 30 or 40 they will die, you get insulin deficiency. or you are born with high insulin resistance. Probably Singapore is one where the best example. Chinese, Malaysian, Indian children. What did they find? Even at birth, Indian children have higher insulin resistance, homocysteine, compared to the Chinese and Malaysian population. So even among South Asians, it is not uniform. But the question is, at the end of all this, okay, cluster 5, and some people say only 4. What is it that they say? These clusters are not going to help you clinically to make the prognosis. Can you say today, on prognosis, whether you will get cardiovascular? Definitely not. You follow next 20 years, you will realize this classification, I'm sure, will change what I have seen 50 years. So that is how clustering is one thing, newly detected average population. Follow-up is different. My take on ultimately, even all these studies, you read 100 papers on this clustering, they say individualize the patient, not by clustering. If I look at family history, look at BMI, smoking habits, hypertension, lipids, HbA1c, if I take all these into consideration, then I can make this what is the future predictability of complication, progress of the disease, much better than this clustering. I feel this clustering is also a part phase. Let me look at this after 10 years.
Right. Dr. Prasanna Kumar, one of the parts of the question, and I think one of our members in the audience, Dr. Khanna, also wants to know how to suspect insulin resistance clinically. In other words, I mean, which is predominant insulin resistance or insulin deficiency? Can we get some clinical clues?
Yes, as you said, clinical clues, but does not quantify that. Very simple, no. I told you. What is the BMI? Obese persons, diabetic or not, have more insulin resistance. Then you have got acanthosis nigricans, and you see PCOD. Right? These are all the things clinically you can make out. This person is more likely to have insulin resistance compared to that, but this is not going to quantify. This gives a clinical suspicion. Yes, this patient has got insulin resistance. 30 years back, everybody was discussing, okay, this is all right. Everybody may not have, because every obese patient has acanthosis nigricans. But how do you make clinically insulin resistance? The definition previously was more than 2 units per kg body weight. Then it became more than 1 unit per kg body weight. So this is clinical insulin resistance compared to others. So there are clinical clues. This gives an idea, but don't think it is sacrosanctum. Probably if you want to quantify the HOMA-IR, HOMA-IS model, if you take, even simple, you take fasting insulin, fasting blood sugar, the ratio gives that. So it is not just only looking at a patient clinically, but also a few investigation that will tell you, or even quantify insulin resistance.
Right. So as we've understood from both Dr. Manoj Barua and Dr. Prasanna Kumar, that probably we as Indians or as South Asians have a significant amount of insulin resistance, but on top of that, there's also beta cell dysfunction, possibly more in our group of populations. But insulin resistance remains an important target to have our drugs act on. So can we come to Dr. Madhu, as to when we talk of a drug that's addressing insulin resistance, would you look at pioglitazone or would you look at metformin? So, of course, Dr. Prasanna Kumar has mentioned insulin resistance. Primarily, we would be looking at the skeletal muscle, but what about the liver? And we have Dr. Srivastav from our audience who has mentioned the drugs which act on insulin resistance. Probably his suggestion is that in type 2 diabetes, possibly we should be biased somewhat towards drugs acting on insulin resistance, because that also helps in NAFLD. And then, of course, we can choose between the different drugs. So, Dr. Madhu, what would be your choice for addressing insulin resistance? Of course, lifestyle is important, weight reduction, exercise, everything is important.
Okay, thank you, Shubhankar, and good evening, everyone. Since we've already understood that insulin resistance is one of the important targets, especially in Indians, in South Asians, and we need to target them with drugs. This question is a natural question: that what will you give them metformin or will you give them pioglitazone, which is better? A short answer to that would be, if we are targeting and we know that insulin resistance is the major target we want to address, undoubtedly it is pioglitazone which scores over metformin. Now let's deal with this question a little in depth. As far as the mechanism is concerned of action, metformin primarily acts on the liver. It's the main action, several actions, but the action on the liver, particularly on hepatic gluconeogenesis, is perhaps the major action, resulting in decreased hepatic glucose output. And its actions on the peripheral insulin resistance, although is described, is far less than what would occur with pioglitazone. The glitazones are the primary agents which directly target insulin resistance at different sites, particularly the skeletal muscle peripheral insulin resistance, as we call it, and even at the adipose tissue level. So in terms of pathophysiology, or in terms of the mechanism of action, pioglitazone certainly scores over metformin. Now coming to the efficacy, there have been some studies as well where they've tried to look at the effects on insulin resistance in terms of HOMA-IR, in terms of adiponectin and other parameters, pioglitazone versus metformin. And in those studies, clearly again, it was shown that probably pioglitazone is superior to metformin in terms of insulin resistance and sensitizing effects. So, but these counts, I would, and in fact, I think Defronzo advises use of glitazones early in the course of management of type 2 diabetes, even to the extent that probably even pre-diabetes or in prevention of diabetes. And we also know that studies of prevention of diabetes, actually, glitazones, they were given up because of the side effects, but their efficacy was far more or greater than what metformin produced. So by all these counts, I think the answer is simple and straight. If it is insulin resistance, we're looking at pioglitazone scores over metformin.
Right. So Dr. Madhur, so then does it not sound logical that we should be using pioglitazone in all our patients of type 2 diabetes? Well, of course, you have just touched on an issue of side effects. So is that the reason why you do not have pioglitazone in all your patients of type 2?
I think the concern about glitazones and which of course was quite a bit with rosiglitazone, and which extended to pioglitazone, is primarily the safety concerns. If the safety concerns weren't there, I'm sure pioglitazone would be the number one drug to use in all settings, even early, probably even in prevention. So it's only these concerns or whatever concerns were expressed and whatever exist out of them in terms after the various studies regarding safety, we can discuss this separately. But I fully agree with you. It's mainly the concerns of safety which are probably a little hindrance to its widespread use or
Right.
universal use.
Sure.
Can I add one
Absolutely.
point?
Yes.
Yeah,
Yes.
actually, what Professor Madhu is saying is quite right. And two things are very important. Metformin doesn't have a documented receptor, where pioglitazone has a receptor. And if I remember well, I think troglitazone has shown almost 50% reduction in onset of diabetes. Of course, troglitazone is not used because of the liver toxicity. But
Exactly.
probably if we do a big trial like diabetes prevention program or that kind of trial with pioglitazone for long term in a large population, maybe we'd see a better result with pioglitazone compared to metformin. And moreover, pioglitazone is one drug which has shown immense benefit in cardiovascular risk reduction, both stroke as well as MI. Of course, that's the different issue because that is usually in the secondary cohort, not in the primary cohort. But not only early, but probably a continuous use of pioglitazone, if possible in type 2 diabetes, is probably what we should do. And I think Indian doctors are doing it pretty well. I mean, for a long time, although there are a lot of controversies, we have not discarded this molecule, and we have continued to use it till
Right.
now.
Right. So we all know the journey of the glitazones, including pioglitazone in our country, and that it had been taken off the market, and that again it's come back. So maybe the discussion related to pioglitazone has become less over the years, and especially with other agents sort of occupying top position. So can we ask Dr. Prakash Keswani to at least to remind us all as to how pioglitazone acts, and as a corollary, if we start someone on pioglitazone today, when should we ask the patient to recheck the glucose? Can we do it after 2 days, or what should be the logical approach? Because patients would like to have the glucoses normalized immediately.
Very right, sir. So the pioglitazone is basically PPR gamma agonist, and these receptors are located in many of the cells. Majority of them are the adipocytes, then liver, then muscle, and so many other tissues. But the major part of the insulin resistance action is concerned is through adipocytes. This pioglitazone gets attached to the PPR gamma receptors on the cell membrane, and this receptor then acts over the nucleus and causes some changes in the DNA and synthesis of so many adipokines. It has been found to increase so many adipokines, like it increases adiponectin, while it also reduces leptin and tumor necrosis factor alpha. And these all working together causes more of action of the insulin. They potentiate the action of the insulin, and thus they improve the insulin effectivity, increases sensitivity, and lowers the blood sugar. This is the mechanism through which they improve the sensitivity and causes improvement in the glycemic levels. But when we give the patient this pioglitazone, unlike that of the sulfonylurea, as you told, that patient wants aaj goli liya, by tomorrow blood sugar should get lower down. This is not seen with this kind of the drug. This gradually modulates many of the adipokines and other receptors, and usually the effect do not appear by 7 days, but we can see reasonable effect by 2 weeks. And with time that increases by 4 weeks, we can have a very good effect of lowering of the blood sugars. So it usually takes time, and the blood sugar levels go down gradually with the pioglitazone.
Right. So that's something very important piece of information that you've shared, so that when we advise this medicine, we should also advise our patients that don't rush too fast. So recheck maybe in another 2 to 3 weeks time. Before that, we'll be unnecessarily disappointed with not seeing results. Right. So we have understood the mechanism. So Dr. Barua Manoj, so how does it compare with other oral agents in terms of its glycemic efficacy? It may address insulin resistance very good. It may have excellent action in improving adipokine and all that, but is it effective as a glucose lowering agent?
Yeah, it's effective, but then the effect is pretty modest. I won't say that it's like sulfonylurea.
So when you say modest, so which
I
stronger
consider
ones?
0.7, 0.6 to 0.9, and that's a modest. And in that range, you have DP4 inhibitor, SGLT2 inhibitor, and pioglitazone. And sulfonylureas initially, most of our patients, they do respond well, but actually the failure rate of sulfonylurea is very. If you look at half a decade data, you can see that all sulfonylurea responding population would be failing on that. Many of them. That's another story. I mean, initially the response of sulfonylurea pretty fast, and that's why our observations are always skewed. We think that they are very potent, but if you look at a large population, the mean changes over a period of 5-6 years is not much different, even from DP4 inhibitors that I have shown. Now, I won't look at pioglitazone as I mean, its efficacy only as a glucose lowering agent. I think it fits into the entire armamentarium because it takes care of many other issues, the basic problem of insulin resistance. And you don't expect a drug which primarily acts on the insulin resistance to act on the beta cell, because the failing beta cells will not secrete insulin in presence of pioglitazone. You need other molecules. So it's like it's like asking that whether Sachin Tendulkar can play good football or good hockey or not. I mean, it's basically it's associated with the initial phase where insulin resistance is a primary factor. Many beta cells are functioning. Yes, that phase, probably first couple of years of onset of diabetes, it will be very good drug, but alone even along with metformin or alone. But on a later phase, it may not be.
Okay, so from your figure of 0.7, 0.8%, somehow my understanding has been that it's more efficacious than that. But would the other panelists also agree on this? Less than 1%?
I would think it could cross 1% also. And not only that, more important aspect of glycemic control with pioglitazone or any glitazone for that matter is its durability. I think Manas did touch about the fact that sulfonylureas, the effects are not durable. The biggest advantage of the effects of pioglitazone, apart from the HbA1c lowering, is the durability effect over years. It remains and it's sustained, and that's, I think, a big advantage.
Right, great.
Many of the studies have quoted up to 1. So HbA1c reduction by 1 and over 1.1.
Right, yeah, okay. So we have a question in the chat box. Dr. Deepak Agarwal. GLP-1 receptor agonists have immense potential to reduce weight. Now, oral option is also available. Do you believe that starting it early in the course may have an impact on reversal of IR? Who would like to take that? Yes.
Now, let us think about GLP-1 receptor analog as well as if you look at pioglitazone. Now, almost the father figure of insulin resistance, D. France. 5 years back, he comes up and presents a paper in ADA. What is the paper? When the HbA1c is more than 10 or even 11, there's got two groups. One group takes insulin as per the criteria. Other groups, he gives pioglitazone, GLP-1 analog. That time, liraglutide was available. And of course, metformin. What did he show at the end of 6 months? Beautiful study. They have taken weight, HbA1c, blood sugar, BMI. They have also seen the insulin reserve doing the stimulation test. At the end of 6 months, he showed more than 50% of them had reached a A1C of 7. So this is D. Franco's cocktail of pioglitazone, which reduces the insulin resistance, GLP-1 analog reduces the weight, and metformin should always be the first drug. Today, now we have got oral, so you can replace probably the injectable GLP-1 along with a oral analog. So that is how this combination is excellent. Or even metformin is always first. No guidelines in the world says it is second except about European Society of Cardiology, because there are no diabetologists like us. So they said you can use SGLT2 ahead of it. We don't agree. So if you take this combination of GLP-1 along with pioglitazone, I think it's an excellent combination. Not only gives cardiac protection, reduces weight, whatever disadvantage of pioglitazone is countered by that. So insulin resistance at the beginning, it's a good thing to start.
So you suggest combining the two?
Yes, definitely.
GLP-1 and pioglitazone.
Yes, definitely. Why not? If the patient can afford and he is there, definitely we can combine after metformin. Whether you give metformin 1 day or 1 month, the second line can be this even beginning, because as all of us are telling, beginning of diabetes is insulin resistance, but worsening of diabetes, beta cell failure. Using it at the end and then say it is not useful, probably is not. Same GLP-1 receptor analog also. If you use both of them beginning, your results are much better than using at the end.
Right. So we have already heard that there are concerns about the use of the glitazones, and pioglitazone is the only one that's available to us now. So what are these concerns, Dr. Prasanna Kumar?
See, you can look at short term and long term. All of us have used it more than 2 decades. I was in Marrakesh when rosiglitazone data of 5,000 patients were shown. That is the first time anybody did a clinical trial of 5,000. Even FDA does not. Fantastic drug. What happened went away. Then when pioglitazone came, and then we see the acute short effect we see is anemia, edema, weight gain. The weight gain, though they say 2 to 3 kg, there are patients where it says 3 to 15 kg weight loss, even in 70-year-old. Don't ask me why did they put pioglitazone in a 70-year-old lady. So the concerns are it can worsen or it can trigger a acute pulmonary edema. Please do not use it in elderly patients and those who have got subclinical cardiac problems. I would rather use it in young patients. So anemia, edema, weight gain are the problems. And also flash pulmonary edema has been described. What is the other short term? Many people say that bronchitis, pulmonary infections are more common. Why this black box warning came is because of bladder cancer. A lot of people say this data is good. Some people say conjunctural, it is a coincidence, and it is not big, whatever it is. The long term, this one like osteoporosis or osteopenia, bladder cancer. These are some of the concerns why even today it has gone out of this. Slowly it is coming up. But if you look the whole prescription pattern in India, Asia, pioglitazone does not even form 5% of the prescription. Better drug, good drugs which can lose weight, less side effects have come.
Right. And so we come to Professor Madhu. So where would you not use pioglitazone? What would be your gospel for the audience?
Okay, I think this to some extent or to a large extent stems from Dr. Prasanna Kumar's replies on the concerns of pioglitazone use. So as he already said, in the elderly, especially with significant cardiovascular disease where heart failure is a risk, and especially if your patients already have a NYHA 3 and 4 heart failure, will definitely not like to use it. And in patients who have a lot of edema, because this also tends to cause edema. So in edematous states, whether it is CHF or whether it is renal failure with edema, we'll use it with caution. I would not like to use. Although, mind you, pioglitazone is a safe drug insofar as the GFR or renal failure is concerned per se, but it's this sodium water retention which puts a big question mark on its use in that group of patients. Elderly women, particularly because of the tendency to cause osteoporosis, I would not like to use in an elderly woman, besides other reasons, even for this reason. And if there is a high risk for bladder cancer, I'll use it with caution. If somebody has bladder cancer, of course, it's a total no-no. I think these are some of the areas. Obese patients, although people say, that it'll cause further weight gain, don't use it. Maybe this will be discussed later by some other panelists, but this weight gain is supposed to be a healthy weight gain. And because it also induces adipogenesis, which is actually beneficial in several ways. So that weight gain of 2-3 kgs or more may not actually be that harmful. So I will not mind using it despite the obese status in some patients, but trade-off being a gain of a few kgs of weight. And that's where probably combinations that we'll talk later might be of use.
Right. So
macular edema is another.
Yes.
Macular edema.
Yes.
Macular
edema we will not use.
Sure. So I find myself in a difficult situation where I may have started, or maybe someone else has started. The patient is on pioglitazone for the last 15 years, 20 years, and doing quite well. But now the patient is, let's say, 65, 70 years of age, maybe a lady. So what do I do, Dr. Madhu? Do I stop the pioglitazone? The patient's glucose has been quite well controlled. Weight, heart failure have not been a concern. But with your issue of osteoporosis and fractures, so should we now stop it?
I would tend to, switch over to another drug once the age crosses 70, for example. Especially it's a woman in the postmenopausal period, certainly we'll think of other options. I have done that in a few patients where people were on pioglitazone and actually I shifted them to a safer. Now we have options. See, earlier there were no options. Now options are available. And if those options are available, especially with low hypoglycemic risk, I would tend to switch to such patients to an alternate drug.
Well, I mean, that's exactly what I also tend to do. But I must also share that many a time I've found the glucose control becoming much more difficult now that I've taken off the pioglitazone. That's a real problem at times.
The other thing about, a patient having taken pioglitazone for that many years, this whole issue about bladder cancer is supposed to be a cumulative dose-related effect. So the more the number of years that the patient has taken, that risk also actually becomes more and more real. So that would be another, reason for discontinuing besides the other factors which I mentioned.
Sure.
Yeah, sir,
Okay.
Professor Madhu, can I ask a question to Professor Madhu? Sir, in your experience or rather in your opinion, what could be the optimal years or continuously can use this molecule? Like, because the audience might be also wondering, so how
No,
much?
there is a cumulative dose which has actually been given. Offhand, I can't tell you the figure, but it becomes a real issue when used in high doses, as is used abroad. They use 30, 45 milligrams a day. And then when you use it for several years, that's when actually I fully agree with you, the risk of bladder cancer may be an important concern. And in a country like ours, where we even tend to use 7.5 and don't use more than 15, that may not be a major factor. I do agree with you to that extent. That is
Okay. Can I ask all of the senior people who are on the panel this evening, so how many instances of bladder cancer have you seen in patients with pioglitazone? Dr. Madhu?
I have not seen a single case.
You've not. Dr. Prasanna Kumar?
None.
Dr. Keshwani?
Sir, I have also not seen even a single case, but the problem which I faced was gain of weight up to the 6,
Yeah.
up to 8 kgs in a year.
Sure.
Initially, when we
Yeah.
used to prescribe up to 30 or 45 milligrams.
Right.
So with that much increase of the weight, I have not been able to continue it for much longer time, for 1 year or 2 years or 3 years.
Right. And Manoj?
No,
bladder
sir, I have not seen a single case where I could
Right.
attribute
So,
it particularly to pioglitazone.
I personally am not very convinced that there is a bladder cancer issue to it. But having said that, I have seen one patient, and he was in the government service actually, and then of course, and we are following up now. It's 10 years down the line. Of course, we have stopped the pioglitazone, and he's doing quite well till recently. Anyway, so we
Sir, one more.
yes.
Sir, the government of India also had passed some notice that this drug should not be started as the first line drug for the treatment as far as concern of the bladder cancer. Does it stays there or?
It's still there. I mean, that has not been changed. Once it was brought back, and that it should not be the only drug that you use. It
Yes.
should only be add-on to other agents, and also the dose should not go beyond 30 milligrams and so on and so forth. That still stays. Right. So we have already heard, and hints have been left by Dr. Madhu and others about the side effect of weight gain, fluid retention, whether there could be other agents that can be added with pioglitazone. And in that context, SGLT2 inhibitors already has taken center stage in the management of type 2 diabetes. And we are now already sort of taught, and we have understood to reorient our goals in treatment of diabetes from just looking at glucose levels to actually trying to protect the organs. And SGLT2 inhibitors definitely have a role there. And there's a recent paper in the Lancet which suggests that early use of SGLT2 inhibitors, even before any cardiovascular events, may confer a long-term cardiovascular protective effect. So, Dr. Keshwani, so would that be another evidence to start this class of drugs early? As Dr. Prasanna Kumar was saying, European College of Cardiology or whatever, they suggest that type 2 diabetes should be started with SGLT2 inhibitors.
This fact seems to be what we have heard about the legacy. As in the patients in the extended DCCT, those patients who were with the intensive control had lesser chances of development of complications later on, even after the stoppage of that study. Similarly, in this study in the Lancet, a big number of the patients were included, and it was seen that those patients who were given SGLT2 inhibitors in the first or second year of the start of the therapy, and at the end of the 3 years, they had much lesser cardiovascular complications. So this effect, what we can say the legacy effect, but this is a very short period. And what we see in majority of our patients who develop diabetes, it takes usually, not in all patients, but it usually takes couple of years or up to 10 years before they develop majority of their macrovascular complications. So to say that at the end of the 3 years, there are lesser cardiovascular complications, and that is because of the SGLT2 inhibitors, we cannot say that this is because of this legacy effect. But of course, we know that SGLT2 inhibitors, when they are prescribed, they have definitely cardio and renal benefits. So we can assume that this can have legacy effect, but there doesn't seems to be any mechanism by which we can say this can occur, because of the later on also SGLT2 inhibitor mechanism can help in reduction of cardiovascular disease.
Right. So we have Dr. Verma raising questions about how serious are the concerns raised with pioglitazone in relation to bladder cancer and heart failure. I think we have addressed that issue. And if it is so, is it beneficial in reducing cardiovascular disease? So most likely the question in Dr. Verma's mind is, on the one hand, you say it worsens heart failure, and on the other, it reduces cardiovascular disease. So what is it in balance? Maybe Dr. Madhu?
Yeah, I think there is no doubt that pioglitazone has a clear-cut cardiovascular risk reduction effect. And this is in terms of the MACE or the overall incidence or events related to cardiovascular disease. The only problem which we mentioned regarding cardiovascular safety was with regard to heart failure. It's not the cardiovascular events per se, and there is no question, and several studies have demonstrated significant cardiovascular benefit. And when we think of combining two drugs, actually we might be adding to the cardiovascular effects, beneficial effects of both. So there is no question about the cardiovascular safety. It's only a precaution in heart failure, especially if it's NYHA 3 and 4.
Dr.
Right.
Madhu, do we have CVOT trials on pioglitazone?
I'm not too sure whether CVOT trials of the kind of SGLT2 are available.
So when you have better drugs, where CVOT trials are, many drugs you don't use except metformin, where you don't have CVOT trial. So when you have a drug which has got a definite endpoint of CV, not just parameters improving, lipid improving, endothelial dysfunction improving, hard endpoint 3 or 4 point MACE, people will always try to, why is it that GLP-1 analog SGLT2 accepted? Because of CVOT trial. So that way, when it is approved one, people will go for it rather than say indirect parameters to say probably it is cardiovascular benefit. So this is how I think as it stands today, people want evidence to say rather than choosing it.
No, pioglitazone does have evidence in terms of long-term cardiovascular event endpoints.
Yes.
What I was mentioning was the studies were not as critically done as with SGLT2 inhibitors, but it's not that there are no endpoint trials.
Yeah, so the CVOTs, there was a time when it was not mandated. And once again, now possibly FDA no longer mandates CVOTs. So it was a window period when the SGLT2s, the GLPs, and also TPP4 inhibitors had to pass through it. So what we have understood is that we have in pioglitazone and in SGLT2 inhibitors two very useful agents for management of type 2 diabetes, both of which would not cause hypoglycemia. Pioglitazone possibly has favorable cardiovascular effects. SGLT2 inhibitors have cardiovascular benefits, also have renoprotective effects. So what about bringing the two together? So will it be a win-win situation, and will it not also maybe mitigate using one SGLT2 inhibitor with pioglitazone may mitigate a little bit the weight gain and the fluid retention adverse effects of pioglitazone? So, Dr. Manoj Borua,
Yeah.
what are your thoughts? So, of course, if we want to look for hard clinical evidence, trial evidence, maybe
Yeah,
we won't have much. But
Yeah.
still, what are your thoughts on this?
Yeah, actually, this seems to be a very attractive option because one, the adverse effect of one drug will be, neutralized by the other one. So synergistic, at least for the secondary prevention cohort, patient already having MI or stroke in that population without heart failure, of course, both the drugs can show immense reduction. Of course, we don't have clinical evidence for the reduction in terms of cardiovascular events will add to each other. I mean, numerically that there will be more benefits or not, but that's an attractive option. And again, regarding the glycemic efficacy of this combination, whether there will be an additive effect, synergistic effect, we don't know. And personally, I would say of late, we have been using a lot of DPP4 and SGLT2 combination. Probably in the back of our mind, we have set aside pioglitazone from this combination. We are using pioglitazone with metformin, with sulfonylurea a lot. But whenever we think about SGLT2, the best companion for SGLT2, we have chosen the DPP4 inhibitor as the best companion. So I think we need a broad consensus on it and some more evidence, but it's theoretically and mechanistically also. I mean, it seems to be a very good option of combining these two drugs. Whether pioglitazone induced heart failure will be reduced by SGLT2 inhibitor, that again a question which remains to be answered, because we don't have to, even in the big trials, we had more patients with metformin, and the pioglitazone number of patients on pioglitazone in those like EMPERF trial or DECLARE trial, they're very minimal. So it's very difficult to comment on that.
Right. So we have all heard about weight gain as a problem with the use of pioglitazone. We have also heard from Dr. Madhu that weight gain may actually be because of increase of good fat in the body. So would Dr. Prasanna Kumar use pioglitazone in an obese type 2 diabetes? And many of our type 2 diabetes are obese.
65% of my patients are obese, even the data last 40 years. Second thing is, let us say I start my pioglitazone, patient puts on 2 to 3 kg, whatever your theory, fat is bad, good fat, bad fat, anywhere fat is bad according to me, right? So that way, patient is also worried. Patient always, sir, I have put on 3 kg of weight. So it's always patient choice. And patient says, I don't want, even if you say you're putting on good fat, bad fat is gone, he's not convinced. And we know 3 kgs of weight gain, whatever method, is going to increase HbA1c 1%. So that way I use it only younger person. I will not even go to 70. A lot of people have a subclinical heart disease, which will get
Dr. Kumar, but at the same time, we are all agreed that pioglitazone does reduce HbA1c.
Agreed. There are
So
better
if you
drugs.
say
There are better drugs. So don't say that pioglitazone. What is the usage in India? We have got 45,000 patients, not even 5%, whether landmark trial and all. Why? People are not that, except few people who watch for it. Even if you take the prescription pattern, endocrinologists and all are, it's a minuscule population. And what is the growth of SGLT2, gliptin, GLP-1 and exponentially increased? I don't agree that it is something fantastic drug. We should continue after 20, 30 years using it. So I will always use a drug which is safer, which does not increase weight, whatever way, good, bad fat, whatever. So I am very skeptic, and I don't use it beyond 50 years also, because somebody comes with a flash pulmonary edema, ischemic heart disease. So this is how my practice is.
Right. And so if you use it with SGLT2 inhibitor, will it mitigate the weight gain?
Whether it does or not, I'm not happy with this combination unless you give me long-term safety, efficacy, and great advantage over others.
Okay. So that was Professor Prasanna Kumar, Dr. Madhu. So do you think a fixed dose combination of glitazone with pioglitazone and SGLT2 inhibitor will serve useful purpose in type 2 diabetes?
First, we need to agree that combining the two drugs have additional advantages. That's the first step. Fixed stroke combination will follow. So at the moment, I don't think we would have clinical trial data to support the fact that fixed drug combination of these two are much better than giving either of them alone. In terms of combining, I think I'm aware only of one trial where they looked at a combination of the two versus pioglitazone versus SGLT2 versus some other drug and not any of these drugs, where they found an added benefit or in terms of cardiovascular MACE after a few years when the two were combined. Heart failure was better addressed by the SGLT2 and pioglitazone by the MACE itself. But beyond that, I'm not aware of any other specific trial which has actually shown that the two combining the two will actually result in neutral weight or no weight gain, or the side effects have been actually taken care of and the edema is compensated for, although theoretically it should. So I think we need to await further data before we make that sweeping conclusion. But yes, there is promise and there is need for research in that direction.
Do you think there could be anything adverse on the bone front? Because with canagliflozin, we had some concerns about bone health, and with pioglitazone,
Correct. That
maybe
is one
canagliflozin is
concern where the side effects actually might add up.
okay. Right. So we have another question, Dr. Agarwal. So maybe Dr. Keshwani, you take this one. So Dr. Madhu did mention about 7.5 milligrams of pioglitazone, for which there are not much trials. I'm not aware. But so the question is, do we get similar effects on insulin resistance with pioglitazone at lower dose? Meaning you do not have the side effects, but you have the good effects at 7.5 milligrams. Do you believe in this?
If we remember the previous days, we used to freely prescribe up to 45 milligrams. After a break since 2008, we did not prescribe it for a very long time. And still in my mind, there's a reservation that this drug is going to cause weight gain. And once we stop this drug, we will not be able to control in a better way. They will require more drugs. And starting with 7.5 milligram, as we discussed earlier, the effect appears very gradually. And many of the times we find it difficult to see the effect or impact of adding of pioglitazone in 7.5 milligram. So even if a patient wants to, if we want to start the lower dose, it will be better if we start with the 15 milligrams, and after a month or so, we can try to reduce it to 7.5 milligrams. Of course, there is problem of gaining weight. That is the biggest problem with what I find with this drug.
Right. So
will be difficult. Starting with 15 and then reducing to 7.5 may have some effect.
Okay. I must admit, I have actually zero experience with use of 7.5 milligram. So I want to learn from the other panelists. What are your thoughts on 7.5? Do you use it? If yes, then do you find it useful? Manoj?
I have never used 7.
Okay, so we are on the same boat.
I think 7.5 as well. I've heard that people use it quite commonly in India.
Yeah.
But it has been withdrawn. Most of the companies have withdrawn 7.5 probably recently.
Okay.
They're coming back to 15. And I don't think there are enough clinical data to suggest, or pharmacokinetic or pharmacodynamic data to suggest that it is safe as well as efficacious. I think that is stretching it too far. I think we should stick to 15 to 30 milligrams.
Okay, fair. So I think we had a good discussion and we had questions from our audience. I don't think we have left any questions unanswered. So we think we are looking at exciting times in management of type 2 diabetes. While we have access to practically all the other agents that anyone else in the world has got, we also are in an advantageous position at times that we have different combinations. And we are also aware that why in many an occasion, the rest of the world follows India actually in taking up those combinations. Today, maybe we may deride triple drug combinations, but triple drug combination is now is approved in the West by US FDA as well. So this is a new combination which we are likely to see, pioglitazone with the DPP4 inhibitor, with an SGLT2 inhibitor. And of course, as we all understood that the uses, the utility, the potential advantages are there, but it remains to be seen if this combination, fixed dose combination, gives actually the promised or the expected advantages. But of course, we need different combinations and permutations to suit the individual needs of our patients. And maybe this will help us manage some of our type 2 diabetes better. So I thank all our panelists for making this discussion so engaging and also enlightening. So thank you, Dr. Prasanna Kumar, Professor S.V. Madhu, Dr. Prakash Keswani, and Dr. Manush Borwa. And of course, thanks to Intas for providing us this platform. And of course, we shouldn't forget all our colleagues from across the country who have joined in and encouraged us with interesting questions. Over to Intas now for the conclusion.
Thank you, sir. To you also for such a nice session.
Good evening, doctors.
Sure.
Good evening, doctors. Today we had the privilege to host one of the best panel what we could think about in the field of endocrinology, with significant contribution, shared amongst them. And the topic which was given for them to address was on insulin resistance, which is a commonly experienced condition by the Indian practitioners. And so we were expecting a lot of questions to come through on this particular question, and that's the same situation we have witnessed today, with almost 1,535 doctors attending today's session, which is a record in itself for us for this particular program. I believe that each of the attending doctors would have got their queries clarified on this topic from these elite panelists what we had today. So I would like to thank individually each of the panelists, Dr. Prasanna Kumar, Dr. S.V. Madhu, Dr. Prakash Keswani, and Dr. Manas Barua for giving the insight. There were some gray areas, wherein they came out with their thoughts and tried to clarify doubts of the attending doctors. Thanks a lot for the same. Endocrine Talk Show, just to bring to your notice, was was a seed basically which took birth in the mind of Dr. Shubhankar Chaudhary, and we are seeing that so many episodes of that has gone through, and various topics were addressed during this time. So we have a significant amount of almost 1,100 to 1,200 crowd every time attending, and today, as we saw, that we have crossed that numbers and we have reached out to 1,500 doctors. So I would like to even individually thank each of the attending doctors for being a part of this program, and definitely I cannot end this program without showing our deep gratitude, Dr. Shubhankar Chaudhary, who has helped us to carve out this program in such a beautiful way. Thanks a lot to all the panelists, all the attending doctors, and definitely to our moderator, Dr. Shubhankar Chaudhary. Have a nice weekend ahead.
Thank you very much.
Good night, sir.
Bye-bye.
Bye.